Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric Kelly talking with Jason Jarvis. This is the second episode of our tropical medicine update for the autumn semester 2023. This episode, we will continue on with the conversation and discuss Schistosomiasis and Leishmaniasis. So, Leishmaniasis, that's here in Europe. It was in Malta when we both lived there. Is it in the U.S. as well?
It is. Much to my surprise, I was not expecting that, but Leishmaniasis, just like dengue and just like malaria, is vector-borne, and it's not just vector-borne; it's insect vector-borne, and it's a flying insect. So, whereas dengue and malaria are mosquito-borne infectious diseases, one being viral, one being parasitic, Leishmaniasis is vectored by the sandfly bite. Leishmaniasis is a parasitic disease, so it's in the same grouping as malaria, but whereas the malaria parasite is in the it's phylum Apicomplexa, subphylum Sporozoa. Leishmaniasis is in the same family of protozoal parasites as Giardia, as Trichomonas vaginalis. So these are and Trypanosomiasis, I might add, both American and African. So these are the Mastigophora, which are flagellated parasites. So they have a long tail that they use to swim around, basically.
And they swim around in the blood, don't they?
Yes, they get into the blood from the sandfly bite, and then they go in and they start infecting cells that are not part of the bloodstream necessarily. Leishmaniasis is, I would say, this is theoretically easier to avoid than malaria. So the best way to avoid Leishmaniasis is to stay away from these sandflies. We've got a couple different genera of these sandflies in the what they call the Old World Leishmaniasis. So that's everything on the east side of the Atlantic Ocean, from North Africa to India. That's generally considered the endemic range. So that's your Old World Leishmaniasis, and that is the phlebotomous genus sandfly. And then on the western side of the Atlantic, so Central South America, and now a little bit here in North America, we have the Lutzomia genus sandfly. The parasite itself is something that there's not really a practical way to get rid of this parasite because it is considered a zoonosis. So it's going to be in the animal population in these endemic areas. So dogs will have it. Just about any mammal that lives in the endemic areas is susceptible to having Leishmaniasis. So this is, for practical reasons, going to be virtually impossible to get rid of. But in much of the same way as malaria, the hope for humanity is probably laying in the form of a vaccine, not necessarily eradicating the parasite.
You think a vaccine's coming?
I wouldn't be surprised if someone is working on it. Leishmaniasis has a very, very broad endemic range. As I said, it's all over Central and South America, Mexico, just now getting into the U.S., and we have it in North Africa, Middle East, and also in India. So it is very, very widespread. I think the only place we don't really have it is like East Asia and Australia. I don't believe we have cases of it there. So I think it's certainly worth getting a vaccine together for this, given that you have this animal reservoir, that there's just no practical way to get rid of that, I would say.
both sides of the pond have similar signs and symptoms of Lesh. Is that right?
You can. There are, just going off of memory here, I think there's maybe 30 different species of Leishmaniasis. And if we're talking about old world Leishmaniasis, we get, I'm going from memory here. You can, this was actually the first infectious, or the first tropical disease I ever saw in the flesh was Leishmaniasis. When I was stationed in Basra, southern Iraq, we had an American with Leishmaniasis on his hand, and he had the cutaneous version of that. And what that looks like, if you imagine, it's a large ulcer in the skin, right? So the skin overlying it has completely eroded. So you're essentially looking into the body when you're looking at someone with an ulcer. Think of like a really bad blister that you've de-roofed, and now you're sort of looking into that person's body, at a superficial level. So that's the kind of the classic cutaneous Leishmaniasis presentation. The border of that ulcer will be raised and indurated. So indurated just means that it's hard to the touch. And in the center of the ulcer, you don't really have many parasites there. So the parasites are at the border of this ulcer, sort of eating their way outward. So you can think of it as like a forest fire, where all the action, so to speak, is right on the edges where the fire is spreading, or in this case, the parasites are spreading. So that is cutaneous Leishmaniasis. You have that in the old world and the new world. In the old world, you can also have visceral Leishmaniasis, and that is also known as Kala Azar. And I know that's a Hindu term for, the name eludes me right now. So visceral Leishmaniasis, you now have splenomegaly, and I believe hepatomegaly too. I think it's both. I think it's hepatosplenomegaly. And what you see in those patients, you see a very, very large, enlargement of the abdominal cavity, looking at it from the outside. Once that person recovers, so if someone has Kala Azar and they recover from it, then you have a third Leishmaniasis manifestation called PKDL. So this is called post-Kala Azar dermal Leishmaniasis. And if you imagine someone with smallpox or mpox, it looks a little bit like that. So they have these sort of small raised nodules spread over the skin in sort of random patterns. So that's pretty much. Yeah. So that's PKDL. Wow. That some people get after they've had visceral Leishmaniasis. And then the fourth variety of Leishmaniasis is the mucocutaneous, which I believe is only found in the New World versions of Leishmaniasis. So what we see here in the New World, North South America, we're seeing cutaneous and mucocutaneous Leishmaniasis. And then in the Old World, you've got cutaneous, you've got visceral, also known as Kala Azar, and then you have the post-Kala Azar dermal Leishmaniasis.
So is that a continuum? So if you get a cutaneous version and you just don't treat it, it's going to spread to be visceral? No.
So as I said, there's upwards of 30 different species of Leishmaniasis. So I don't have a chart right in front of me, but I know that on the New World, for example, you have two or three species that are the dominant species, and it's the same in the Old World. So for whatever reason, the New World species don't cause visceral Leishmaniasis. So you're not going to see PKDL over here either. You're just going to have the cutaneous and the mucocutaneous. And then on the old world, they have all three, or you have all the versions of leishmaniasis in the old world, but not the mucocutaneous, where it gets into like the mouth and the nose, and you have these huge erosions that go into there, sort of like almost like tertiary syphilis.
And is this terminal, or can you die from leishmaniasis?
You can, but this is kind of like dengue fever, where it's primarily a disease of morbidity, not necessarily mortality. So it can be very disfiguring, particularly the mucocutaneous version. The treatments are not they're not standard therapies. So these are things like pentavalent antimony is one that comes to mind. These are very toxic medicines, and not the typical sort of medicine that a medic would just have in their backpack routinely. But again, if you're wanting to be the well-prepared medical provider deploying into these areas, you should have some of those anti-leishmaniasis drugs.
But we're not seeing this in Europe yet. We're only seeing the cutaneous.
Yeah. So the cutaneous version is, and I'm just going from memory here, this is mainly what we're seeing in the Middle East and Northern Africa. You have the cutaneous version. In fact, I remember from my Hunter's Tropical Medicine text, there's this old picture of someone in the Middle East with cutaneous leishmaniasis on their face, and they call it Jericho buttons, was the term they used there. The visceral version of leishmaniasis is mostly found in sub-Saharan Africa, or let's just say Africa, because the sandfly is endemic all over the continent. So mostly Northern Africa and the Indian subcontinent.
So for the visceral leishmaniasis, there are drugs available. Have you heard of any of them that are starting to become drug resistant? I mean, I'm just thinking, worst case scenario is now we have visceral leishmaniasis that's going to kill you, but you have drug resistant versions.
Drug resistant leishmaniasis, I have not heard of that discussed. That doesn't mean that it's not a thing. I just haven't heard of that.
It's scary enough. Imagine having a version that just won't die.
Yeah, fortunately, the vast majority of our parasitic diseases we're not seeing like microbial resistance or antimicrobial resistance coming from those. So, from everything I've read, if you look at just as an example, helminthic infections, so looking at, tapeworms, roundworms, and so forth, I've never heard of any of those becoming drug resistant. And I'm not sure why that is, other than, so they have slower replication cycles. So parasites have slower replication cycles than bacteria and viruses. So bacteria replicate so fast that you have lots of opportunities for mutants to form that may be resistant to the antibiotics that you're giving at that particular time. Whereas the replication in your parasites is so much slower, I don't think they can replicate fast enough to mutate out of the treatment that you're getting. One very notable exception to that is malaria, where the malaria drug resistance has really taken off in Southeast Asia. A lot of that was due to conflict. So all the Indochina wars of the 50s and getting into Vietnam in the 60s and 70s, where malaria was rampant and we were treating it, and compliance wasn't always great with the patients or whatnot. But you just had this recipe for malaria that wasn't sufficiently treated, and as a result of that, we now have a huge amount of drug-resistant malaria in Southeast Asia, and we hope that doesn't spread farther than there.
And part of that is it was over the counter for a while.
Yep.
And you and I were teaching in Thailand, and it's a crime to have the drug without a prescription. They've really locked down on that.
Yeah, we were there, and you could buy almost anything over the counter except for narcotics. But you could get pretty much any antibiotic. You could get steroids. You could get lidocaine injectable, but not malaria drugs.
So for back to leishmaniasis. So far there isn't a drug resistance. I'm wondering if people who get leishmaniasis, visceral leishmaniasis, they're a bit motivated to take the full regimen of antibiotics, whereas when you have someone with some random bacteria or tuberculosis is rampant as well, they're just taking the antibiotics or the drugs until they feel better, and then they kind of just bin the rest of the regimen. I'm wondering if leash and your helminths as well, you're saying that there isn't a drug resistant there yet, or is just people are highly motivated to take the full treatment?
I've got a couple theories on this, and these are just theories. But a lot of your anti-helminthic therapy is sort of a one and done thing. Like you come to the clinic with malnutrition, in your child or whatever, and then they're like, okay, this is probably ascariasis. So you get your drug, and then that's it. That's enough to knock that.
It's a one-shot wonder.
Yeah, it's a one-shot wonder. If you look at your leishmaniasis regimens, these are very toxic drugs, and I don't think they're taking these people. They're not handing them this really toxic drug and telling them, take one a day for the next week, and call me if you don't feel well. I would suspect these are going to be done on an inpatient level.
So that's the difference. They're doing it in hospital with a healthcare provider watching them.
Yeah, I believe that's going to be the case with leishmaniasis.
So the medic who's going to see leishmaniasis in Europe or America, they're going to see probably the cutaneous. So what can we do besides? I mean, we have drugs, but what can we do for this wound, this leishmaniasis wound?
Well, so these will heal on their own. If it's a very large ulcer, I'm sure there's going to be a scar. So it's something where it's noticed and it's hopefully treated, and that's pretty much it. So the main thing though is going to be avoiding the sandflies. Like I was saying earlier, the avoidance is, well, things are theoretically easy sometimes, and in practice not so easy. But it's going to be easier to avoid a sandfly bite because the sandflies, whether it's the phlebotomist or the Leutzomia genera, they're very poor flyers. So it's like they've recently evolved wings or something. So they don't just buzz around like flies and mosquitoes. They spend most of their life just sitting on a surface on the ground typically. And when they fly, they have this sort of hopping flying motion. So they'll start flying, they're beating their wings. They'll go about a meter up in the air, and they'll just do this sort of like, little parabola flight path, and then land again, and then it'll start beating its wings again and fly again. So if I'm in an environment where leishmaniasis is prevalent, one of the things the most important thing I could say you would do is just not sleep on the ground. Right? If you sleep on the ground, the sandflies can easily get to you, and they seek out blood meals. The females seek out blood meals just like your mosquitoes do. So you just want to sleep, on the second floor of a building, or in a hammock, or on top of a vehicle or something like that, where you're going to have less exposure to the sandflies.
I noticed that the bites that I get in Malta are generally the knees down. And after 10 years of going down there and getting bit by sandflies, I have to say I'm disappointed that I haven't had a cutaneous leishmaniasis experience, but time will tell.
Yeah, I think leishmaniasis is just an gozo. I don't know if they have that on the main island yet.
So it's a rash. So if you, the dermatologists hate it when we say this, but a wet rash, you put dry stuff on it, or a dry rash, you put wet stuff on it. Is that the same here for the cutaneous rash?
Yeah, again, it's going to present like an ulcer, right? So it's like a blister that you've unroofed, And I would, I mean, I'm just thinking what I would do with this. The case I had in Basra, Iraq years ago, we basically just medevac that person up to Baghdad where they had the facilities to take care of that. So I'm just going to basically just keep a gauze dressing over that until it heals. And one of my main concerns there is that we don't have more, excuse me, we don't have more sandflies getting on the edges of that bite and picking up those parasites and transmitting them onward.
So you cover it so it won't spread to somebody else.
Yeah, you cover it. So yeah, and again, this is not
communicable. Yeah. It's a sandfly is the carrier. Yeah, I guess
so. It's going to be vector-borne.
So we'll have to see over the next few years if we're going to see more and more Leishmaniasis in Europe and the States.
Yeah, like I said, it's in the animal population, so the animals are there. Like the animals aren't going anywhere. So unless there's an effective way to eradicate the sandflies, I think for the U.S., I think it's here to stay. I don't think we're gonna get rid of it now that it's here.
So DEET would probably work, wouldn't it? Because they'll land on your leg, taste the DEET, and then they'll jump off.
Yeah, absolutely. Insect repellent should work. Off the top of my head, I have no idea what the insecticide or insecticide resistance is in sandflies. But I mean, if they're anything like mosquitoes, then yeah, they probably will develop a resistance at some point.
The last one is Schistosomiasis. So we're talking about the 4 tropical diseases that's shown up in France and Europe and also in the U.S. So of the 4, we can talk about schisto as well. So Schistosomiasis, I read that it's showing up in Corsica and here in Europe. Is it in the States as well?
So human schistosomiasis, which encompasses 5 species of schisto. So human schistosomiasis is not currently, it's not on the European mainland as far as I know, and nor is it here on the North American continent. But we do have here in the States, as well as you guys over there in Europe, we do have what we call a zoonotic species of schistosomiasis. So typically that's going to be found in the duck population. So schistosomiasis is it's a helminth, right? So helminth is just a fancy word for a worm. And we've got a couple different, we have 3 phyla of worms overall, right? You have the nematodes, which are the round, unsegmented worms. So that would be like a lot of your intestinal worms and things like guinea worm disease and so forth. You have your annelida, which are your things that are segmented worms. Segmented worms. So these would be your earthworms, leeches, and bristleworms that you find at the bottom of the ocean if you're a scuba diver. And then the third phyla is the platyhelminths. So these are flatworms, and those are divided into 2 phyla. 2 classes. So you have class cestode, which are the tapeworms, and then you have your trematodes, which are your flatworms. So the flatworms, the trematodes, include the schistosomes, which are these are flatworms that actually burrow through your skin, and that's how they affect you. And then you have all the other trematodes that are parasites that are not schistosomes. Those are all foodborne. So those are going to be found in various types of shellfish, typically, but usually it's going to be on some kind of plant that someone consumes. So your human schistosomes include you have your Schistosoma japonicum, your Meikongi, Hematobium, Intercalatum, and Mansoni. The one that is the most prevalent in Africa is Schistosoma hematobium, And to my recollection, I looked at this article you're referring to a little while back. To my recollection, this was what apparently happened was they have a hybrid species in Corsica, which is owned by France. They have a hybrid species of Schistosoma hematobium and Schistosoma, I believe it's bovis. So it's a schistosoma that infects cows typically. Mm-hmm. So some genes got scrambled somehow, and we have this hybrid Schistosoma hematobium that is now endemic to Corsica. They're in the Mediterranean.
So this is easily treatable, though, isn't it? There's a drug that can just wipe it out.
Yeah, it's given. So you treat these cases with praziquantel,
which works for other things as well, doesn't it?
Yeah, praziquantel is used for pretty much any trematode infection. So things like Paragangliomyces. That's what you would get from eating, crustaceans that were infected with this, or any of the liver flukes, the gallbladder flukes, and so forth, is given praziquantel.
So if this shows up to someone in Europe, what's their signs and symptoms, or what's going to tell me that, other than looking at their fecal matter, which in London school we definitely enjoy doing fecal smears and seeing the shit. It's one of my favorite wee beasties that are coming out of you, because it has that little hook on the Schistosomiasis ovum, and it's just so obvious and good, easy to find. So when that was on the quiz in London, I was quite happy to see that. But So what's the signs and symptoms of my casualty going to be?
Yeah, so the one with the hook on the side, that's from Schistosoma mansoni, which is endemic to Africa, but that is, I believe, mostly found in Asia. So you think of like rice paddies and places like that where you've got standing water with lots of snails, which is our intermediate host in this particular life cycle. So just real quick, the life cycle is you have snails that are infected with this that are in irrigation canals, slow-moving rivers, lakes, ponds, rice paddies, etc. You have snails there; they're infected. You have the release of the parasite from the snail. They just basically come out of their flesh, and you have this thing called a cercaria that swims around looking for its host. And the host could be a human, it could be a duck, it could be a cow, whatever that host or whatever that particular species wants. It's going to go for a host, and it's very common for these to burrow into the wrong host. So where you have, for example, duck schistosomiasis, so that's very common here in North America as well as Europe. So people will have duck schistosomes burrow into their skin and then die because they're not suited for life inside of us, particularly, and that's where you get swimmer's itch. So if it is the right host, though, the cercaria burrow through the skin, they lose their tail, and then they find their way in the circulation to the liver. They develop into adults in the liver. You get a male and a female that will pair off, and then they migrate down into either the venules around the lower gastrointestinal system, or in the case of Schistosoma hematobium, which I believe is what they have in Corsica now, Schistosoma hematobium, the mated pair will work its way down into the venous plexus surrounding the bladder. Okay, so that mated pair will then dwell there for years to decades, shedding eggs through the wall of the blood vessel that they're in, and into the bladder in the case of Schistosoma hematobium, or in all the other species, the other 4 human species, the eggs go from that blood vessel into the gastrointestinal system. Those eggs are then either excreted into the environment. If that environment happens to be a similar water source as where this person first picked it up, then they're just helping this life cycle along. The eggs will hatch into the form called the myricydia, and then the myricydia swim around and penetrate snail tissue where they replicate into the next stage, the cercaria. So that's the life cycle. Schistosomia hematobium. This is one of the more pathognomonic diseases that we come across. So what these people will typically present with is they're going to present with blood in the urine. And this has been around so long that the ancient Egyptians thought that there was, in addition to teenage girls having a menstrual cycle, you had a male menstrual cycle. So these boys would be peeing blood. You have boys peeing blood, and in fact, they were just infected with Schistosomia hematobium. But boys doing what boys do, they're out swimming in the Nile River and all the irrigation ditches and so forth. So they picked up this parasite. So that's the number one thing I'm looking for in Schistosomia hematobium. We're looking for blood in the urine, and we're looking for environmental exposure. So if I have a patient with bloody urine, that's where that travel history comes in really handy. So I want to know, okay, where have you been in the last 6 to 12 months? And if they've been in Oslo their entire life, then I would say, well, this is probably not Schistosomia hematobium, so I'm going to cross that off the list because that's not endemic to Oslo. But if they've traveled to one of these endemic places, then that Schistosomia hematobium would be very, very high on my differential list.
Yeah, so they took a holiday weekend to Corsica. Then, even though you're in Oslo, you may have to think outside the box.
Right, and so not only are this is a very specific exposure. Like you have to not only be, if I go to Kenya, it doesn't matter what I'm doing in Kenya, I'm exposed to malaria because the mosquitoes are everywhere, right? So it's not just being in that environment; it's also having history of water exposure, where you went down and stuck your foot in the water, or you swam, or something along those lines. So classic example for me, anyway, is our mutual colleague Trent went down to Uganda, was swimming in Lake Victoria, and ended up with schistosomiasis. So, yeah.
I cringe to think of all the places I've swum in my life.
Yes.
and so far, no schisto, but
yep.
Who knows? Yeah. So those are the 4 diseases we wanted to talk about in this podcast, because those are the 4 that we're starting to see in Europe and 3 of them in North America. So what's your take-home message with this, Jason? What for the medic that's working in Texas or Florida or anywhere here in Europe? What's the take-home message on how to start learning these tropical diseases and be better at what they do? Yeah,
I think the easiest thing for most people, working professionals, their time's at a premium. So, I could just say, well, yeah, pick up these tropical medicine textbooks and just read them. Most people are probably too time strapped to do anything like that. I really think your best option is to go to the CDC website, go to the WHO website, and look up the place that you're going and see what diseases do we need to worry about, and it will list those, and it'll talk about the exposure risks. Look at your exposure risks, right? You're in that place where maybe I have all 4 of these diseases where I go. So let's say I'm going to Uganda, which probably has leash, although I'm not 100% sure, but let's just say it does. So I'm in Uganda. I want to avoid any mosquito bite because they have dengue there. They have Plasmodium falciparum. They have pretty much every other mosquito-borne disease you've ever heard of. So I want to avoid mosquito bites at all costs by wearing long sleeves, long pants, shoes, insect repellent, right? Sleep under a mosquito net. Those things that we typically do to avoid those mosquito bites. While we're in Uganda, I'm going to tell people, please do not swim in the lake. And if you just can't help yourself, then what you can do then to mitigate schistosomiasis is as soon as you come out of that water, you need to vigorously dry yourself off with a towel, and almost to the point of like abrading the skin, because the schistosomes, or I should say the cercaria, are not necessarily they're not penetrating the skin while you're in the water. That happens as you start drying off, and that sort of helps the parasite move in towards hair follicles and places where they like to burrow into the skin. So they're going to be on the skin typically when you come out of that water. And if you just couldn't help yourself, like it was on your bucket list to swim in Lake Victoria, I understand. I might be tempted to do the same thing, even though I know the risk. Again, you can have this mitigation of vigorously toweling off, and then understanding that's not going to be 100%. You can still get schisto, so just keeping a close eye on yourself for any possible signs and symptoms. One of the other early symptoms of schisto, and this is based on the life cycle, is you have the Katayama fever. We're going to see this 3 to 6 weeks after primary infection by Schistosoma mansoni japonicum or hematobium.
I see that. Abdominal pain, diarrhea, bloody stool, blood in the urine. But that's not every case, is it? Like if you get schisto, you're not going to get this every time.
Yeah, so that's one of the things to look out for. So that the listeners can look up Katayama fever.
So be fastidious about brushing off or drying off. What about soap? I mean, soap. I'm thinking of bacteria. It kills bacteria. It's not going to kill the schistosomiasis.
I mean, soap is great for viruses and bacteria, but I think once you get up to the parasite level, they're just so big that they're not going to be as affected by soap as the smaller organisms. Now, washing yourself with soap is always a good thing when we're talking about any kind of skin infection, but all the research I've done in schistosomiasis, where they talk about, okay, you had the exposure, now what do you do? I've never heard soap and water as a treatment option. I've heard, or as a mitigation thing, it's always vigorous toweling off. So it's like it's almost like debriding these cercaria off your skin, so to speak.
So we've had the whirlwind tour of dengue, leishmaniasis, falciparum, and schistosomiasis, and every 3 months we'll bring you in and do a tropical disease update. So we definitely look forward to our next talk, and we'll see what that will be. But do you have any the last bits of suggestions for the listeners who are interested in tropical disease?
Like I said, WHO, CDC. You can always look at PubMed if you have more time for reading some of these more detailed articles. I will be I'll be paying a close eye on the R21 vaccine, seeing how that rollout goes in Africa. It's going to be great for the population that lives there. Again, I'm also interested in travelers to those parts of the world. If I'm going to South America, I'm getting a yellow fever vaccine, right? If I'm going to East Asia, I'm getting a Japanese bee encephalitis vaccine. I hope to see a day soon where I'm going to the tropics, I'm getting a malaria vaccine.
That would be a relief to have that worry off as we travel around Asia and Africa. If anyone has any questions, is there a way they can contact you, or do you want to just have them email the college and we can forward it to you?
They can email the college. I am also the newsletter editor, so on the second or third page or fourth page, there's a little blurb in there on how to get a hold of me. It's editor. I think it's editor@quorum.edu.nt or something like that.
Jason, thank you. It's been educational every time we have this chat. I look forward to the winter edition of the Tropical Medicine Update.
All right, looking forward to that as well. Thanks, Aebhric.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.